Hello everyone, I'm really pleased to have the opportunity to share with you today an important clinical topic: the clinical applications of blood gas analysis. Blood gas analysis is a fundamental yet crucial diagnostic tool that we frequently use in daily clinical practice. It not only helps us understand a patient's respiratory and metabolic status, but also provides vital information regarding acid-base balance, oxygenation, and ventilation. Whether in critical care, emergency medicine, or specialties like respiratory and cardiovascular medicine, blood gas analysis plays a key role in guiding treatment and monitoring patient progress. Today, we will dive into the basic principles of blood gas analysis, explore the most commonly measured parameters, and examine how these values are applied in clinical settings. My goal is that by the end of today's session, you'll have a better understanding of the role and value of blood gas analysis across different clinical scenarios, which will hopefully improve our ability to assess and manage patient conditions more effectively. Before we dive into the specific applications of blood gas analysis, let's first take a closer look at what blood gas analysis is and what it entails. This slide provides a detailed description of blood gas analysis. It's not just about numbers, it's about understanding the story these numbers tell about a patient's health. Through blood gas analysis, we can obtain several key pieces of information. The first key piece of information is about the analytes involved in blood gas analysis, which include hydrogen ions, oxygen, carbon dioxide, as well as electrolytes and metabolites. These analytes are crucial in assessing a patient's overall health and can provide valuable insights into several physiological and pathological processes. In addition to the 10 directly measured parameters, the EGI-30 offers the ability to calculate over 20 additional parameters, significantly expanding its diagnostic capabilities. These calculated parameters include values such as the anion gap, base excess, and the P/F ratio, among others. These additional parameters, when used alongside the measured values, provide a comprehensive view of a patient's respiratory, metabolic, and circulatory status, enhancing the diagnostic accuracy and helping clinicians make informed treatment decisions. The second critical piece of information is that blood gas analysis reveals the physiological or pathological state of the body. Proper understanding and use of blood gas and electrolyte analysis can help accurately interpret most respiratory, circulatory, and metabolic disturbances in critically ill patients. Blood gas analysis should be performed by trained individuals in a variety of settings, including, but not limited to, hospital laboratory, hospital emergency department, patient care area, clinic laboratory, laboratory in physician's office, intrafacility critical care transport, pulmonary diagnostic laboratory, operating room suite, cardiac catheterization laboratory, perinatology department. Its application across these diverse clinical environments underscores its importance in modern healthcare. Blood gas analysis is routinely performed in hospital labs to monitor patients in various clinical departments such as ICU, emergency rooms, and surgical wards. It provides real-time data essential for the management of critically ill patients, helping to assess their respiratory, metabolic, and acid-base status. In emergency departments, blood gas analysis is crucial for quickly assessing life-threatening conditions such as respiratory failure, metabolic acidosis, and sepsis. It allows clinicians to make rapid, informed decisions about the patient's condition and treatment plan. In intensive care units ICU or coronary care units CCU, blood gas analysis is performed regularly to monitor critically ill patients, particularly those on ventilators or in shock. It helps clinicians assess the adequacy of ventilation, oxygenation, and circulatory function. In outpatient clinics, blood gas analysis can be used for patients with chronic conditions like asthma or COPD, who require regular monitoring of their respiratory function and oxygen levels. It is also useful for evaluating the impact of treatment on chronic metabolic conditions. Blood gas analysis is critical during surgery, especially in complex or high-risk procedures. It helps monitor the patient's oxygenation, ventilation, and acid-base balance in real time, ensuring proper management of anesthesia and maintaining homeostasis during surgery. Blood gas analysis plays a key role in the care of newborns and pregnant women. It is used to monitor the respiratory and metabolic status of premature or critically ill infants, as well as assessing maternal acid-base status during labor and delivery. One of the most important functions of blood gas analysis is assessing respiratory function. This process can be broken down into 3 key events, each of which plays a critical role in ensuring that oxygen is effectively delivered to the tissues. The first step in oxygen delivery is the uptake of oxygen from the alveolar air into the bloodstream. Oxygen enters the lungs through inhalation and diffuses across the alveolar capillary membrane into the blood. Blood gas analysis, specifically measuring partial pressure of oxygen, provides valuable information on how effectively the lungs are oxygenating the blood. Impaired oxygen uptake can be caused by conditions such as pneumonia, pulmonary edema, or pulmonary fibrosis, which hinder the diffusion process. After oxygen enters the bloodstream, it binds to hemoglobin in red blood cells and is transported through the circulatory system to the tissues. Oxygen delivery can be compromised in conditions like anemia or heart failure, where either the hemoglobin levels are low or the circulatory system fails to deliver oxygen efficiently. Finally, oxygen is released from hemoglobin in the blood to the tissues, where it is used for cellular metabolism. This release is facilitated by the difference in oxygen partial pressure between the blood and the tissues. Factors such as the body's temperature, pH, and carbon dioxide levels can influence this process, which is why monitoring these parameters is critical, particularly in critically ill patients. The partial pressure of oxygen is a crucial parameter that reflects the efficiency of oxygen uptake in the lungs. It directly measures the amount of oxygen dissolved in the blood plasma, providing an indication of how well oxygen is being transferred from the alveoli in the lungs into the bloodstream. This is a key component in assessing the adequacy of blood oxygenation. Partial pressure of oxygen plays an essential role in the diagnosis of respiratory failure. When partial pressure of oxygen levels drop below normal ranges, it suggests that the lungs are not adequately oxygenating the blood, which can be caused by conditions such as chronic obstructive pulmonary disease (COPD), pulmonary edema, pneumonia, or acute respiratory distress syndrome (ARDS). By measuring partial pressure of oxygen, clinicians can identify the severity of respiratory failure and determine the need for oxygen therapy or mechanical ventilation. In addition to diagnosing respiratory failure, partial pressure of oxygen is critical for monitoring supplemental oxygen therapy. In patients requiring additional oxygen, partial pressure of oxygen levels help determine if the current oxygen therapy is effective or if adjustments are needed. For example, if the partial pressure of oxygen is too low despite supplemental oxygen, it may indicate the need for higher oxygen concentrations, or perhaps a change in the method of oxygen delivery, such as the transition to mechanical ventilation. Monitoring partial pressure of oxygen over time allows clinicians to track the patient's response to treatment, adjust oxygen supplementation as needed, and ensure that the patient maintains optimal oxygen levels to support cellular function and metabolism. Measuring partial pressure of oxygen is clinically important for diagnosing, assessing, and monitoring patients with acute or chronic respiratory conditions or respiratory failure caused by factors other than respiratory disease. For example, hypoxemia refers to decreased oxygen content in the blood, and the values of partial pressure of oxygen can help diagnose both hypoxemia and hyperoxemia. While oxygen therapy is critical for treating hypoxemia, excessive oxygen supplementation can lead to hyperoxemia, which can be harmful, particularly in patients with conditions like acute lung injury or ARDS. Monitoring PO2 levels ensures that oxygen therapy is properly titrated to avoid complications related to excessive oxygen levels. Partial pressure of oxygen measurement is also crucial in diagnosing and managing acute respiratory failure, which can occur as a result of conditions other than chronic respiratory diseases. For instance, Trauma to the brain or chest, such as a traumatic brain injury or rib fractures, can impair the body's ability to maintain adequate oxygenation, resulting in hypoxemia. Similarly, drug overdose, especially opioids, can depress the respiratory drive, leading to inadequate ventilation and oxygenation, which is reflected in low partial pressure of oxygen levels. In these scenarios, timely blood gas analysis helps to identify the problem and guides the clinical management of the patient. Carbon dioxide is an acidic gas, and as such, partial pressure of carbon dioxide reflects the respiratory contribution to the body's acid-base status. The level of carbon dioxide in the blood is primarily controlled by the rate and depth of breathing or ventilation. Therefore, partial pressure of carbon dioxide provides important evidence regarding the adequacy of alveolar ventilation. Partial pressure of carbon dioxide levels are crucial for differentiating between type 1 and type 2 respiratory failure. These two types of respiratory failure have distinct pathophysiological mechanisms, and partial pressure of carbon dioxide measurement provides key insights into the underlying respiratory dysfunction. In type 1 respiratory failure, the primary issue is impaired oxygenation, leading to hypoxemia and low oxygen levels in the blood, but carbon dioxide removal remains relatively intact. In this type of respiratory failure, peak quota levels typically remain within normal ranges or may be slightly low due to hyperventilation as the body compensates for low oxygen levels. Conditions like pneumonia, pulmonary edema, and acute respiratory distress syndrome (ARDS) are often associated with type 1 respiratory failure. The key characteristic here is the inability of the lungs to effectively oxygenate the blood, while carbon dioxide levels are still controlled. In type 2 respiratory failure, the problem is primarily impaired ventilation, which leads to the inability to remove carbon dioxide from the body effectively. As a result, partial pressure of carbon dioxide levels typically exceed 50 mmHg and can rise significantly, reflecting hypercapnia, excess carbon dioxide in the blood. This occurs when the body is unable to adequately ventilate and expel carbon dioxide, resulting in an accumulation of carbon dioxide. Conditions such as chronic obstructive pulmonary disease, severe asthma, and drug overdose, for example, opioid-induced respiratory depression, are common causes of type 2 respiratory failure. The elevated partial pressure of carbon dioxide levels indicate that the lungs are not effectively eliminating carbon dioxide, which may require interventions such as mechanical ventilation to help remove excess carbon dioxide. The calculated P/F ratio is a key component of the Berlin definition of acute respiratory distress syndrome (ARDS). This ratio plays a crucial role in assessing the severity of ARDS and is used to classify the condition into mild, moderate, or severe categories based on the level of oxygenation. The P/F ratio is critical in ARDS management because it helps clinicians determine the appropriate level of respiratory support, such as supplemental oxygen or mechanical ventilation. This ratio reflects the severity of gas exchange impairment and guides treatment decisions in critical care settings. Blood gas analysis typically uses arterial blood samples to assess oxygenation and ventilation, but venous blood samples can also provide valuable insights, especially in certain clinical situations. Venous oxygen saturation reflects the balance between oxygen delivery and oxygen extraction by tissues. It is a key parameter in assessing whether tissues are receiving adequate oxygen supply relative to their demand. Venous oxygen saturation is particularly useful in critically ill patients or those experiencing hemodynamic instability. In these patients, monitoring venous oxygen saturation can provide valuable information about the adequacy of oxygen delivery and the ability of tissues to extract oxygen effectively. Lactate is a metabolite of glucose, produced when oxygen delivery to tissues is insufficient for the demands of cellular metabolism. Under normal conditions, glucose is metabolized via aerobic processes in the mitochondria, but when oxygen supply is inadequate, hypoxia, the body shifts to anaerobic metabolism, leading to the accumulation of lactate. Increased lactate levels are an early and sensitive indicator of an imbalance between tissue oxygen demand and oxygen supply, making lactate a valuable marker in assessing tissue perfusion. Monitoring lactate levels helps guide clinical decision-making, assess treatment effectiveness, and improve patient management in conditions such as circulatory shock, sepsis, and post-resuscitation care. The Surviving Sepsis Campaign (SSC) guidelines provide international recommendations for the management of sepsis and septic shock. In the 2021 guidelines, one of the key recommendations is the measurement of blood lactate levels in adults suspected of having sepsis. Elevated lactate levels are often one of the first signs of tissue hypoxia and circulatory shock, and they serve as a sensitive marker for detecting the severity of sepsis. In patients with sepsis or septic shock, the SSC guidelines suggest guiding resuscitation efforts by aiming to decrease serum lactate levels, particularly in patients with elevated lactate levels. This recommendation emphasizes that lactate clearance is an important indicator of the adequacy of resuscitation and tissue oxygenation. Monitoring lactate levels helps clinicians assess whether interventions such as fluid resuscitation, vasopressors, or other treatments are improving tissue perfusion and oxygen delivery. Why is this important? Elevated lactate levels reflect the body's inability to meet tissue oxygen demand, which is often seen in the early stages of shock or severe infection. Persistent or rising lactate levels despite resuscitation efforts can indicate inadequate tissue perfusion and guide clinicians to adjust their therapeutic approach, potentially shifting to more aggressive interventions. Lactate and venous oxygen saturation scale are frequently used in clinical practice to guide treatment, especially in critically ill patients. Elevated lactate levels are a red flag, signaling that tissues are not receiving sufficient oxygen to meet their metabolic needs. When lactate levels are high, it suggests that there is tissue hyperperfusion or tissue hypoxia, which can occur in conditions like shock, sepsis, or severe trauma. The first line of assessment for tissue perfusion is straightforward. The higher the lactate level, the greater the urgency to intervene. Lactate is a sensitive marker of oxygen deficit at the tissue level, and its elevation indicates that cells are relying on anaerobic metabolism due to insufficient oxygen supply. Therefore, timely measurement of lactate levels is critical in patients presenting with signs of impaired tissue perfusion, such as hypotension, tachycardia, abnormal peripheral perfusion, or altered mental status. When there are signs of impaired tissue perfusion, the next step is to measure central venous oxygen saturation. Central venous oxygen saturation reflects the balance between oxygen delivery and oxygen extraction by tissues. If central venous oxygen saturation is normal, it suggests that oxygen delivery is adequate despite the elevated lactate. However, if central venous oxygen saturation is low, it confirms that tissue oxygen delivery is insufficient and suggests a need for aggressive resuscitation efforts. In cases where central venous oxygen saturation is normal or only slightly low, measuring the delta P-CO to the difference between arterial and central venous CO2 can further help in diagnosing tissue hyperperfusion. A high delta P-CO2 value can indicate that the tissues are extracting oxygen inefficiently due to impaired circulation, even when overall oxygen delivery seems adequate. Acid-base disorders are common in clinical settings, particularly in patients with respiratory failure, shock, and other critical conditions. These disorders can significantly impact the patient's overall health and organ function. Blood gas analysis plays a key role in identifying both the type and presence of acid-base imbalances, providing essential information to guide clinical decision-making. This slide outlines a systematic approach to diagnosing acid-base disorders. When faced with a patient who has suspected acid-base disturbances, a structured approach is crucial for accurately identifying the type of imbalance and determining the underlying cause. By following this systematic approach, clinicians can accurately identify the type of acid-base disturbance, determine its cause, and initiate appropriate treatment. Electrolyte imbalances are often associated with various health conditions, such as kidney disease, heart failure, hypertension, and liver disease. These imbalances can lead to serious complications and even require emergency treatment, Monitoring electrolytes regularly and correcting imbalances is critical in managing these conditions and preventing more serious outcomes. This table shows some of the most common causes of electrolyte imbalances, which can occur due to various underlying conditions. Electrolyte disturbances are often linked to disruptions in kidney function, fluid balance, or metabolic processes, and can have significant effects on multiple organ systems. Monitoring hemoglobin Hb or hematocrit HCG levels is essential in detecting excessive blood loss and guiding blood transfusion therapy. In clinical practice, blood transfusions are typically considered when a patient's hemoglobin concentration drops below certain thresholds, depending on their clinical condition. The NICE guidelines for blood transfusion provide specific recommendations for the threshold at which transfusion should be considered, based on the patient's hemoglobin levels. Today, we discussed in detail the important clinical applications of blood gas analysis, particularly its critical role in monitoring and managing acid-base balance, electrolyte disturbances, and blood oxygenation. Through blood gas analysis, clinicians can quickly assess a patient's oxygen delivery, acid-base status, and electrolyte balance, allowing for timely and effective treatment decisions. We also explored how key parameters such as lactate and central venous oxygen saturation help assess a patient's hemodynamic status and tissue oxygenation. In critical conditions such as acute illness, shock, and respiratory failure, blood gas analysis provides valuable information that helps us assess treatment efficacy and adjust therapy. Finally, we reviewed the critical role of hemoglobin and hematocrit in blood management. Through these clinical applications, we can see that blood gas analysis is not just a diagnostic tool, but a crucial component in ensuring optimal patient treatment and management. Thank you for your participation today. That concludes today's session. If you have any questions, feel free to ask. Thank you.